On this first video today, we are going to look at a normal EEG together and learn about the features of normal EEG. As you watch these videos, you'll see that I do tend to repeat myself a lot, and I feel that that's helpful to just hear the concepts over and over, then they stick in your head as you're learning. One thing I want to point out from the outset is that EEG is not easy. This isn't something that you could pick up within a few weeks like you can during regular rotations where, at the end of a month you feel like you're pretty confident. EEG is very difficult. There are a lot of subtleties, and do not get frustrated and don't expect to know everything right away. It just takes time, and it takes time and practice. So let's go ahead and start looking at our first study. Now, before I look at an EEG, there's a few things that I want to know. The first is the history, and a lot of people don't like to know the history. I prefer to. This is an 18-year-old with a history of seizures. Now, to orient ourselves, the first thing that I like to do is to go ahead and look at the settings up on top. And this is the NATIS program. Most programs do have the same settings. Sometimes the taskbar looks a little different, but these are the things that you should look at when you're starting. You want to look at the low frequency and the high frequency filters. This is telling us what frequency of activity that we're looking at on the study. Brain activity varies in frequency. We can see activity that's very low frequency, 1-2 hertz, even less than that, up to hundreds of hertz. But for routine EEGs, the only frequencies that we're interested are between 1 and 70 hertz. And so that's what these filters are. They're just telling us we're going to look at activity greater than 1 hertz and less than 70 hertz. And those can be changed if necessary. The next thing we want to look at here is the notch. This is a filter that is filtering out activity at 60 hertz. And we do that because electrical devices that are plugged in generate artifact at 60 hertz. So that just erases that for us and makes the recording look cleaner. This is the sensitivity. This is telling us the amplitude of the activity that we're looking at. And on the NATIS program, we can actually use the keyboard to increase and decrease the amplitude of the activity that we're looking at. Now, usually the standard sensitivity is 7 microvolts per millimeter, but this is a younger patient, and younger patients do have higher amplitude activity because their skulls are thinner, and this is quite high, and so I just will turn it down a little bit. For most adult patients, you can use the 7 microvolts per millimeter sensitivity. This is the time base. This is just telling us how spread apart the waves are. So we're looking at 15 millimeters per second. We can go ahead and spread that out if we need to, or we can squeeze it in, but I like to look at it at about 15. The other thing we want to look at is we want to just orient ourselves to the montage, and that's just how we're looking at the combinations of electrodes. Before that, let's just go ahead and review what the electrode names are. Now, all of the electrodes in the 1020 system, and that's the International System of Electrode Placement, they're named with both a letter and a number. And the letter tells us where anatomically on the head the electrode is placed. So FP is frontopolar. We've got frontal, central, parietal, temporal, and occipital. The electrodes all have a number as well, and that number is odd if it's on the left side and even if it's on the right side. We also see a Z on the electrodes in the midline. So FZ, CZ, and PZ are right down the center. We look at these electrodes on the EEG as combinations, and we see electrode chains that are the potential difference between 2 electrodes. And that's how we always look at electrical activity. It's the difference between 2 electrodes. And we look at these chains as a combination of different electrode combinations called montages. This is a montage that is used very frequently, and it's a very good screening montage. It's called a double banana montage because it looks like 2 bananas on either side of the head. On this side, we see the left. This is the left temporal chain. It's going down around the temporal lobe to the occipital lobe. So we're looking at FP1 to F7 to T3 to T5 and O1. And then here we have the left parasagittal chain going FP1 to F3 to C3 to P3 and O1. Now, I just wanted to point out one thing. In this electrode here, F7, even though you would think that's frontal, that's more anterior temporal, so just remember that. Then we have the exact same on the right side. We've got the right frontal polar going down the parasagittal chain, and then we have the right temporal going down the temporal chain. And here in the middle, we've got FZ to CZ to PZ going right down the vertex. Now this montage shows the left side over the right side, and personally I don't care for this montage. I like to look at left over right, and so on the Natus program you can actually right click and you can pick whatever montage you want. So I like a left right program. And so now we're looking at left and right parasagittal and left and right temporal, and here's the midline. This is better, I think, because you can actually directly compare side to side, hemisphere to hemisphere. It's easier to see subtle abnormalities when you can directly compare each hemisphere. Okay, now when we start looking at an EEG, the very first thing we want to look at is the background activity. This is very important. It tells us a lot about the patient. The background activity is the activity we see in the back of the head, in the posterior quadrant. We see it when the patients are awake, but in a restful state with their eyes closed. Now here is the background activity, and just to point out, this is 1 second here, and what we want to do is look at a lot of different features of the background. The first feature we want to look at is the frequency. And to get that, we can just count how many waves we see in 1 second. So if we count, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, about 9.5, 10 hertz. So that's a normal frequency of an adult. Normal is 8.5 to, anything over 8.5 to 12, 13 hertz is considered normal. If it's 8 hertz, that's not normal. Some people refer to the posterior dominant rhythm as the alpha rhythm, which really technically isn't correct. The posterior dominant rhythm should be alpha frequency, and that is, well, actually that's not even true, because alpha frequency is above 8 hertz, and the posterior dominant rhythm should be greater than 8.5 hertz. We shouldn't call the posterior dominant rhythm alpha rhythm because sometimes the posterior dominant rhythm is slower than alpha rhythm. Sometimes it's theta rhythm, which is slower. Now let's go ahead and review what those terms mean. Now alpha rhythm is 8 to 13 hertz. Theta rhythm is slower, that's 4 to 8. Delta activity is even slower, it's 0.5 to 4 hertz. And then we've got beta activity, which is faster, and that's 13 to 30 hertz. So we've got delta, theta, alpha, and beta. Okay, so this patient, we said the frequency of the posterior dominant rhythm is 8.5 hertz. Is 10 hertz, 9.5 to 10 hertz, so that's normal. That's the frequency. The next thing we want to look at is the amplitude, and to do that, we can actually measure it with this cursor. We can click on it, and we can click on the top and the bottom of a typical wave and look over here. That's about 73 microvolts. And in reports, sometimes it's good to give a range. We could say this varies from 20 to 80 microvolts. In some reports, if you have a template, you may not need to say the amplitude, the specifics, but it's always good to know how to measure. So we talked about the frequency, we talked about the amplitude. Now let's talk about the symmetry. And when we're looking at the symmetry, there's a few different aspects we want to look at. So we see that in terms of the frequency between the left side and the right side, we have symmetry. These are, both the same. And in terms of the amplitude, we also want to look at the symmetry. Are the amplitudes symmetric from side to side? And if not, there may be an abnormality. Now looking at this, we see that the amplitude on the right side does look a little bit higher than the amplitude on the left side, and that is normal in most people. The amplitudes are higher over the non-dominant side. We don't say that the amplitudes are clinically asymmetric, that there's clinical significance unless there's a greater than 50% difference. So this would have to be double the amplitude of this in order for us to say that it's clinically significant. Now, other than that, in terms of the symmetry, just wanting to make sure that the the morphology, the frequency, and the symmetry, and the amplitude are the same between the sides. The next thing we want to look at is the organization of the background activity, and that is referring to something called the frequency amplitude gradient, which is very well organized here. This is looking at the changes in frequency and amplitude that occur between the front of the head and the back of the head. Now, this patient has a very nicely organized EEG, meaning the frequency amplitude gradient looks the way it should look. In the front of the head, we have lower amplitude activity that's faster. Now, if we look in between here and here, we see, if we counted these up, there's probably at least 10 waves here. So this is very fast activity in the front of the head. As we move toward the back, we see the amplitude starting to increase, and we see the frequency starting to decrease from fast to slower. So the frequency decreases going to the back of the head, and the amplitude increases going to the back of the head. That means that this is a very well-organized EEG, and the frequency amplitude gradient is normal. When patients are encephalopathic, or if they have some type of brain pathology, you lose this organization. So that's something you always want to look at and comment on in your reports. The other thing that we want to comment about the background is the reactivity. That means that the background changes in response to external stimuli. The easiest one to look for is eye opening. Now here, the patient's eyes are closed because we see the posterior dominant rhythm, which only comes out with eye closure. Then the eyes open and we see attenuation of the background. This is the eye opening here. We can actually see that on the EEG because the eye is charged, and so the eye movements are seen here. And we see the eyes open, and then the background, look what happens. The background's gone. And as we keep going here, we see the eye close, and there's our posterior dominant rhythm again. So that's reactivity. It's reactive to eye opening. Okay, so as we go along here, we see the background still looks really nice, really nicely organized and symmetric. Here the patient opened her eyes again, and we see the background attenuate, and here we see the background come back out there because the eye is closed again. And now hyperventilation is beginning. Hyperventilation is done during routine EEGs because it can bring out epileptiform activities, specifically in patients with primary generalized epilepsy syndromes. This is especially important in kids with absence seizures because they can have, their epileptiform activity come out with hyperventilation. Even if patients don't have epileptiform or they don't have epilepsy, we can see EEG changes from hyperventilation, which we're not really seeing here. The EEG looks pretty much the same. We can see, and some people will see high amplitude slow waves during hyperventilation, and we will see that in future EEGs that we look at. Now I want to back up a little bit here to point out another finding. First of all, this may have caught the eye of some people. Because it is asymmetric, we see this activity here on the right, and we're not really seeing it there. This is just muscle artifact. This very sharp looking activity, darker, faster, that's just muscle, that's EMG artifact. Now here we're seeing the background, and then we see it go away a little bit. It attenuates a bit, it's lower amplitude, and then it comes back. This is drowsiness. When patients get drowsy, their background attenuates. Now sometimes before that, I backed up a page, we can see this kind of activity here. This is from the eyes kind of rolling back and forth. This is eye movement, and that's often the very first sign of drowsiness. So this patient is getting drowsy. The eyes are closed. We see the background attenuating a little bit here, then waking up a little bit. And again, drowsy, and you can just see a change in the EEG here. Even the organization looks different. See how it's just more attenuated, We're not seeing the frequency amplitude gradient as organized as before. So hyperventilation made this patient drowsy. And here again, you can see that loss of that organization with drowsiness. Okay. Now again, the patient's waking up here. Drowsy again on this page. Just see how attenuated this looks compared to this. Now she's waking up. And as we go forward, we continue to see the drowsiness. Now, there are other features that we can see when patients are drowsy, and one is called Vertex Waves. Now, I just want to point out that sleep activity is seen in the vertex. Most of the sleep activity we see is in the center of the head. And so that's where you're going to see a lot of your sleep activity as you're looking in these leads and down here. Vertex waves are a feature that we also see during drowsiness or stage N1 sleep. So during stage N1, we can see those horizontal eye movements, and then we can see the background attenuate. You see loss of your posterior dominant rhythm, and then you can see vertex waves. We may not see very good ones here, and so I may point those out later in the recording. I think we see a few, and I'll point them out also on future EEGs where they are better formed. I don't want to overwhelm you with too many findings. There are some other interesting findings here. These are called posts, and I'll talk about those more later. I just don't want to overwhelm you with too much at once. Now, this is again background activity. The patient is waking up here, and as we progress, the patient's drowsy. We see more of these posts. These are called positive occipital sharp transients, and that's a normal feature during drowsiness. We don't see those in everyone. It's kind of interesting when we do see those. Now we're seeing something new. This here, these are sharp waves we're seeing at the vertex, and those are also known as vertex waves. And those are what I was mentioning earlier we can see in stage N1 sleep or drowsiness. Now stage N2 sleep is the first stage where we really say the patient is sleeping. And we can say that someone's in stage N2 sleep when we see either sleep spindles or K-complexes. Now here's an example of a sleep spindle. It's sort of superimposed after the vertex wave here, and these are they are 11 to 14 hertz, and they're seen in the parasagittal regions, and they're sort of lower amplitude, fast activity. They usually last about a second, and those are indicative of stage N2 sleep. Those aren't very well formed there, so we'll see if we can see some more. But now we know the patient's asleep because we do see those sleep spindles. Now it's important to look at the location of these because sometimes people look at these and think that this is just posterior dominant rhythm because it's sort of similar frequency. But look at the location. We're seeing this in the parasagittal regions. We're not seeing it in the temporal leads here. And this is not awake background activity. This is a sleep spindle. Okay, so as we progress along, we see this is a this is a K-complex. This is a high amplitude delta wave here that we're seeing in all of the leads. And this is also indicative of stage N2 sleep. There are two different types of vertex waves. There are these high amplitude diffuse delta waves, and then another type of K-complex is this. So it's a vertex wave, which is this sharp wave here that phase reverses or points at each other right over the vertex, followed by a sleep spindle. So those are both indicative of stage N2 sleep. And every time you look at an EEG, you're going to want to look and see what stage of sleep the patient went into. This is very important because sleep is activating, meaning it brings out epileptiform abnormalities. So we want to know when we're reading an EEG report if the patient slept or not, because if they didn't sleep, maybe we just missed the epileptiform activity because we didn't catch sleep. Here's more sleep spindles here. And here, sometimes we do see the spindles that are more diffuse and more vertex waves and K-complexes. And here the patient looks like they're waking up a little bit and then going back to sleep, more K-complexes. And this is interesting here. The technician wrote noise outside. Now K complexes got their name from K is from knock complexes, because they noticed that when there was a knock at the door, these would occur. And so it's thought that these can be activated by exterior noise. So that's very interesting that that was noted there. And more vertex waves here. See how these are pointing at each other right at the vertex. So if we go ahead and scroll over here, we can see that the electrode that these two have in common is C3, and that's right in the parasagittal region, which is very typical of sleep activity. So C3, C4, and CZ, that's right at the center. Okay, so as we progress on here, we're not seeing any, I backed up here, we're not seeing any asymmetries. There's, everything looks good here. We're not seeing any epileptiform activity. And here the patient woke up. We're seeing normal background coming back out. Now the patient's moving around, and the technician is getting the patient ready for the photic stimulation. So here, the tech is flashing a light at a certain frequency, which is mentioned here, 3 Hertz, and we're looking to see if there are any abnormalities. Now normally, in normal patients, we can see the posterior dominant rhythm can change to match the frequency of the light flash. Here we do see that. That's called photic driving, and we're seeing this kind of 3 Hertz activity there that is going along with the flash. A lack of a photic driving response is not pathological. Some people have them, some people don't, and like I said, we're not looking for the presence or absence of the photic driving response. What we're looking for is a photoparoxysmal response, and that means epileptiform activity in response to the light. And we can see that in patients with primary generalized epilepsy syndromes. We didn't see anything like that here. And here again, we see nice normal EEG. And again, here we see these eye movements. The patient's getting drowsy. This is just horizontal eye movements. And she's waking up here, and the study is over. So this is a normal EEG. Now, when you're writing your report, you would make sure that you would say that this is a normal EEG in the awake, drowsy, and sleep states, and no epileptiform activity is seen. And we will talk a little bit more later about specifics of how we write findings in normal and abnormal recordings.